This is your supplemental lecture for the cardiovascular system. Here's a quick overview of what this lesson is about. Of course, discussing anatomy of the heart and the great vessels. We know that the heart itself is a pump. This is how we get our blood pressure, for example. So when you think about the cardiovascular system, to really break it down to elementary level, there's two potential problems that you can have. You can either have a pump problem or you can have an electrical problem. We know that when you begin the exam, you always want to start with vital signs. This also includes JVP and pulsations at the carotid pulse, looking at the chest wall and apical impulse, also known as the PMI. When you auscultate, you're listening for S1 and S2 sounds, and then for some, S3 and S4. And you're also looking for any cardiac murmurs. Here's a great diagram that covers the anatomy of the heart and the great vessels. As you'll see that the right ventricle will occupy most of the anterior cardiac surface. And we know that the right ventricle and the pulmonary artery form a wedge-like structure behind and then to the left of the sternum. And here it's outlined in the black. The inferior border of the right ventricle will lie below the junction of the sternum and the xiphoid process. The right ventricle narrows superiorly and joins the pulmonary artery at the level of the sternum. The left ventricle, which is behind the right ventricle and to the left, forms the left lateral margin of the heart. The inferior tip, we call that the cardiac apex, and it's important to know that because this is what produces the apical impulse, which we know as the point of maximal impulse, or PMI. Impulse locates to the left border of the heart and is normally found at the fifth interspace, about 7 centimeters to 9 centimeters lateral to the midsternal line, which is typically at or just medial to the left midclavicular line. So if you know left midclavicular line, fifth intercostal space, you should have a pretty good understanding of where the PMI is at. We also know that PMI is not always palpable, even in our healthy patients without any heart abnormalities. If you have the patient in a supine position, the diameter of the PMI will actually get a little bit larger to about the size of a quarter. We know that if there's a PMI that's greater than 2.5 centimeters, whereas normally it's 1 to 2.5, that would be evidence of left ventricular hypertrophy, or LVH, or heart enlargement. And a lot of times we'll see that in our hypertensive and aortic stenosis patients. And let's say if you're looking for the PMI and it happens to be displaced, lateral to the midclavicular line, or if it's greater than 10 centimeters, that also will suggest left ventricular hypertrophy. It's also important to know the great vessels. We know that the pulmonary artery bifurcates quickly into its left and right branches. The aorta curves upward from the left ventricle to the level of the sternal angle, where it arches backwards to the left and then downward. On the medial border, the superior and inferior vena cava channel venous blood from the upper and lower portions of the body into the right atrium. So just in terms of kind of knowing your landmarks, again, important to know not only for your documentation, but if you know the anatomy of the heart, you can help describe that based on surface landmarks. So you want to know your midsternal line, midclavicular line, the anterior axillary line, and midaxillary line. It's important to know the chambers of the heart and how it's important to the great vessels. So if you visualize the circulation through superior inferior vena cava to right atrium, right ventricle, pulmonary arteries, left atrium, ventricle, aorta, and aortic arch. So some key points for examining the heart. You want to note that the heart chambers and valves and the forward flow of blood from the right side to the left side. And then you want to combine that knowledge with the examination and systematic clinical reasoning, and this will help you correctly identify valvular and heart diseases. So to kind of go over, so the idea is really, if you know the flow of blood through the heart, it'll be easier to identify where there's a potential problem. So we know, of course, that the blood enters through the two large veins, the inferior and superior vena cava, which empties oxygen-poor blood from the body into the right atrium. So, of course, as the blood has already been sent out to the body, and then all the nutrients, so oxygen, for example, is all taken up through the cells, and in order to recirculate, it goes back through. And we know that this is oxygen-poor blood because all the cells were just given the oxygen. So once that oxygen-poor blood is in the right atrium, we know that the atrium contracts, then blood will flow from the right atrium into the right ventricle through the open tricuspid valve. So it's important to know your valves as well. So once the ventricle is full, then the tricuspid valve will shut off, saying, okay, we have enough here in the ventricle. And by shutting the valve, that prevents the blood from flowing backwards into the atrium. Because as the ventricle contracts, we don't want the blood to go anywhere other than out. We don't want it to go back in to the atrium. So the right ventricle contracts, blood will leave the heart through the pulmonic valve and into the pulmonary artery. And we know that the pulmonary artery is the only artery in the body that carries oxygen-poor blood. So pulmonary artery, and then into the lungs. Patient takes a real big deep breath, gets all the oxygen in there, and that's how the blood's oxygenated. So then from the lung to the pulmonary vein empties oxygen-rich blood from the lungs into the left atrium of the heart. Then the left atrium will contract. That blood will go from the left atrium into the left ventricle through the open mitral valve. And same thing as before. Once that left ventricle is full, that mitral valve will shut off. It will close. And again, this prevents that backflow into the atrium. So then left atrium will contract, and then blood will leave the heart through the aortic valve and into the aorta, and then out to the body. So if you can verbalize that, if you can trace a drop of blood through the heart, you'll have a pretty good understanding of the anatomy of the heart and the great vessels. So we know that systole is when ventricles contract. So we're looking at the cardiac cycle. And this is how we get our blood pressure. So systole, ventricles contract. The right ventricle pumps the blood into the pulmonary artery, which is through the open pulmonic valve. Left ventricle pumps the blood into the aorta, whereas the aortic valve is open. And we know that diastole is when the ventricles relax. So we're looking at ventricles here. Systole, ventricles contract, so greater pressure, which is our top number of the blood pressure. And then diastole is when the ventricles relax. So systole is contract, diastole is relax. The blood flows from the right atrium into the right ventricle through the open tricuspid valve. And then blood will flow from the left atrium to the left ventricle through the open mitral valve. So here are some important concepts to know. So let's first talk about preload. And we know that preload refers to the load that stretches the cardiac muscle before contraction. So we think about it this way. The volume of blood, so the amount of blood that's going to be in the right ventricle at the end of diastole, that constitutes preload. So meaning we're prepped for the next beat, we're prepped for the next round. So right ventricular preload can be increased by increasing venous return to the heart. And we know that the physiological changes that can increase the preload or increase the venous return include inspiration and the increased volume of blood flow from the heart itself, the heart muscles itself. You can also have increased blood volume if the right ventricle is dilated, as say a heart failure patient. So that can also increase the preload. So what are some causes that can decrease the preload? That includes exhalation, decreased left ventricular output, and any pooling of blood in the capillary beds or any part of the venous system. Okay, so that's preload. Afterload refers to the degree of vascular resistance to the ventricular contraction. So some sources of resistance to left ventricular contraction include the tone in the walls of the aorta, the large arteries and peripheral vascular tree, which is primarily made up of small arteries and arterioles, as well as the volume of blood already in the aorta. Okay, so we know that with preload, it can lead to volume overload, and afterload can lead to pressure overload. So some pathological increases in preload and afterload, which are called volume overload and pressure overload, produce changes in ventricular function that may be clinically detectable. Okay, so these changes can include alterations in ventricular impulses. You can detect these by palpation and in normal heart sounds. So there are some pathological heart sounds and murmurs that may develop. So the term heart failure is now preferred over, say, just congestive heart failure, because not all patients will present with congestion on initial presentation. So if you call it congestive heart failure, it's important to know that is it congested or not. Contractility, this is again when ventricles will contract during systole. So if you see the term contractility, that's just we're talking about when ventricles will contract during systole. And then the cardiac output, which is the volume of blood ejected from each ventricle during a 1 minute period, is how we come up with the heart rate and the stroke volume. So we know what heart rate is, and then stroke volume is the volume of blood ejected with each heartbeat. So that again, the stroke volume will depend on the preload and the afterload and that contractility. So how do we get the blood pressure? We know that the systolic blood pressure, again, which is that top number, is when there's pressure generated by the left ventricle during systole. Again, there's that contraction. When the left ventricle will eject that blood into the aorta and the arterial tree. Here we also can get our pressure waves from the arteries, which will create those pulses that we have. And then the diastolic blood pressure, as we know, will generate pressure by blood that remains in that arterial tree during diastole. So when the ventricles are relaxed. So in terms of arterial pressure, we know that when the pressure waves moves rapidly through the arterial system, this is what we call the arterial pulses. So some factors that can influence arterial pressure: left ventricular stroke volume, distendability of the aorta and large arteries, peripheral vascular resistance, which is more particular at the arterial level, and volume of blood that is in the arterial system. So when you're obtaining your blood pressure, just as a quick review, we know that you have to make sure that you have the correct cuff size and you have it applied correctly. So if you have a cuff that is too small for the patient, we know that you're going to get a false high reading. And if you get a cuff that is too large for the patient, you'll have a false low reading. So JVP, or jugular vein pressure, reflects right atrial pressure, which in turn equals central venous pressure and right ventricular and diastolic pressure. So we know that the JVP is best estimated from the right internal jugular vein. Okay, so you're going to raise the head of the bed to about 30 degrees. You'll have the patient turn the patient's head to the left. By turning to the left, that's going to expose that right internal jugular. So you can place a centimeter ruler upright on the sternal angle, and then you can place a card or tongue blade horizontally from the top of the JVP to the ruler, so that helps make a right angle. Now your book covers this as well, but in terms of just talking it through. So you want to measure the distance above the sternal angle in centimeters, and if you have a 3 to 4 centimeter elevation, that's normal. Again, you're also, don't forget, you're elevating the head of the bed to 30 degrees. And when you're assessing the carotid pulse, this is here for a reason. However, just as a reminder, just check one side, not both sides at the same time. Please do not choke your patients. So we know that if you feel the carotid pulse, that the upstroke or the beat that you feel, if it's brisk, that's considered normal. If it's delayed, we know that that suggests aortic stenosis. And if it's bounding, if it's coming right out of their neck, that would suggest aortic insufficiency. So you also want to listen with your stethoscope for any bruits. As you palpate the chest wall, you're palpating for any heaves or lifts from any abnormal ventricular movements. So with the ball of the hand, you want to palpate for thrills, and thrill is considered a turbulent feeling that's transmitted through the chest wall surface by any damaged heart valve. So you want to palpate the chest wall in the aortic, pulmonic, left peristernal, and apical areas, which are located here on this diagram, which are also in your book. So when you're assessing PMI, if you feel like a tapping sensation on the chest wall, which is again apex of the PMI there, that's considered normal. If it has a sustained feel, that would suggest left ventricular hypertrophy from either high blood pressure or aortic stenosis patients. If it feels diffuse, then that would suggest a dilated ventricle from congestive heart failure or any cardiomyopathy. So when you're assessing PMI, you want to, of course, assess the location, which we already talked about, amplitude, duration, and the diameter. And that's all on feel. When you're auscultating, you want to listen to the 6 areas for S1 and S2 using the diaphragm of the stethoscope. And then you'll switch it over and listen at the apex with the bell. Because we know the diaphragm is best for detecting the high-pitched sounds, S1 and S2. You can also hear most murmurs and even S4 if it's present. Whereas the bell, you'll be able to hear low-pitched sounds, as in if a patient having S3, and then the sounds of mitral stenosis. So you want to definitely be able to describe and identify any type of murmurs. So you want to remember Miss Ard's and Mr. Ass, that mnemonic, in terms of if it's a diastolic or systolic murmur. So by doing this again, if you palpate the carotid, which again occurs in systole because there's that contraction of the ventricles. So if the murmur coincides with the carotid upstroke, then it's considered systolic. Again, with duration, it could be early, mid, or late. Same with diastolic, early, mid, or late. But if you can have an understanding of Mr. Ard's, Mr. Ass mnemonic, you should be fine. Of course, the more you hear it, the more it'll stick with you. 'Cause sometimes these murmurs can be very hard to hear and sometimes hard to pick up. So if this is not your specialty, it's still important to just try to be able to tell the differences. What I would suggest as you are in your clinical rotations is if you come across a patient, regardless of what they're there for, but if you know that they happen to have a murmur, ask to listen to their chest. When describing the shape of a murmur, which is determined by its intensity over time, some of the terms that you would use is crescendo, decrescendo, sometimes both. As you'll see here on the bottom there, it kind of makes that diamond shape. So there's a lot of examples in your book. We know that crescendo murmur will grow louder, decrescendo will grow softer. So decrescendo, crescendo, decrescendo murmur will first rise in intensity and then fall. You may also have a plateau murmur, and that's basically that has the same intensity throughout. Intensity, which is graded on a 6-point scale, so 1 to 6, will be expressed as a fraction. And I'll show you an example here momentarily. But we know that the numerator describes the intensity of the murmur wherever it's the loudest. And then, of course, the denominator indicates the scale that you're using. So it's the same thing as a pain scale. 2 out of 10, 5 out of 10, 10 out of 10. We know that intensity is influenced by the thickness of the chest wall and the presence of intervening tissues. So grade 1 is very faint. Sometimes we won't even be able to be heard. You have to really be kind of tuned in with this, and it may not be heard in all different positions. Now, it is important, though, that especially if this is not your specialty, or this is not or if it is your specialty and you really are trying to learn this, it's important that whether you're seeing a patient for something completely different, but you know that they have a history of a heart murmur, ask to listen to their heart rate. Or if you think you hear something, go to your preceptor or go to someone on the floor that might have more experience than you to verify that. The more you hear these things, because just reading it is one thing, but to actually hear these things over and over and over again, you'll become more comfortable with them. So that's whether you're listening to the different murmurs in our skills lab, or you're listening to them on an actual patient, or using some other resources. There's some really great resources online that are available as well. Moving on to grade 2 of a murmur. This is where it's quiet, but you'll hear it as soon as you place the stethoscope on the chest. Grade 3, we start to get a little bit louder, so this is considered moderately loud. Grade 4 is loud with a palpable thrill. Grade 5 is very loud with also a thrill. And we sometimes can hear this murmur when the stethoscope is even partially off the chest. Whereas grade 6, it's very loud, has a thrill, and you can even hear it without the stethoscope entirely on the chest. So it may be heard with the stethoscope entirely off of the chest. Pretty amazing. Now, those grade 6 murmurs are easier to hear than obviously the grade 1 or 2. But if you know what a normal heart rate sounds like, if you can get real familiar with that, then you'll at least be able to know that there's some abnormality going on. When we're talking about a thrill, so we know that grades 4 through 6 must have a thrill. And in order to kind of bring the point home of what a thrill is, if you think about the cat purring, so that vibration feel. So the thrill is like the throat vibrations of a cat when it purrs. In terms of quality, you're going to use terms like harsh, musical, soft, blowing, or even rumbling. A pitch is categorized as high, medium, or low pitched. This can also help you determine it depends on what side of the stethoscope you're listening to. So here's a couple examples. Harsh 2 out of 6 medium pitched holosystolic murmur, best heard at the apex, which describes mitral regurgitation. Or is it soft and blowing, a 3 out of 6 decrescendo diastolic murmur, best heard at the left lower sternal border, which would describe aortic regurgitation. So some ways of identifying heart murmurs. You want to review again the time of the murmur. Is it systolic or diastolic? You want to locate where the murmur is loudest on the chest. Is it at the base or along the sternal border, or is it at the apex? Conduct any necessary maneuvers, such as if you want to have the patient, say, lean forward and exhale, or turn to the left lateral decubitus position. Determining the shape of the murmur, for example, if it's a crescendo or decrescendo. Being able to grade the intensity of the murmur, again 1 to 6, where 4 to 6 must have a palpable thrill. To identify associated features, such as the quality of the S1 and S2. If there's any extra sounds, like an S3 or S4. Is there an opening snap or the presence of an additional murmur? And of course, be sure you're listening in a quiet room. So if you're trying to listen to someone's heart sounds, if you're thinking you might have a murmur, and this goes for if you're just even auscultating anywhere on the chest, so whether it be heart or lung sounds, make sure it's in a quiet room. So if you walk into a patient's room and they have the television on, what do you want to do? You want to lower the volume because you want to be able to hear what the heart and the lungs, for example, are telling you.